Yeah. Hi everyone, I'm Dr. Sani Sipai, working in Kanti Children's Hospital, oncology ward for 1 year. Thank you.
Indu sister.
Good morning, everyone. I'm Indu Adhikari and from Kanti Children's Hospital and working in oncology ward of Kanti Children's Hospital. Thank you.
So this is I'm myself Dr. Sudhir Sapkota. I'm pediatric oncologist working in the Kanti Children's Hospital, and I'll be the coordinator for this pediatric palliative care ECO 2 on behalf of the Nepalese Society of the Palliative Care. So this is the introduction of the faculty members, and after that I'll start the introduction of the participants. I'll start with the name that's appearing on my screen. So Dr. Sumit. You are muted, Dr. Sumit.
Good morning, everybody. I'm Dr. Sumit Agarwal, working in Kanti Children's Hospital for the past 2 years, and I look after the pediatric intensive care unit. Thank you.
Thank you, Dr. Sumit. Bandana Adhikari.
Hello, everyone. Good morning and namaste. I have been working in pediatric oncology ward for 15 years as a staff nurse. Thank you.
Himal Sobha Patel. Himal Sobha Patel, are you with us? They will get back to you. Garima Ardal.
Hello, everyone. I am Himal Sobha Patel, working at BP Koirala Memorial Cancer Hospital. I am postgraduate at pediatric nursing. Thank you.
Garima Ardal.
Hi, everyone. My name is Garima, and I'm a new member of Team ECHO in Canada. So I'm working with Dr. Megan Doherty at the Ottawa Hospital, and I'm a first-year medical student. And something about me is I grew up in Nepal, and my family moved to Canada when I was little. So I'm very excited to be a part of projects, that are being conducted in Kanti Hospital and Bhaktapur Hospital. These are places I grew up in. So I'm very excited to be a part of the team.
Welcome, Garima. Can you speak Nepali?
Yeah.
Swagat cha.
Thank you. Dhanyavad.
I'm in touch. Okay. Juna Dungana.
Namaskar everyone, I'm Juna Dungana, working as a clinical dietitian in Kanti Children's Hospital Oncology Unit since 1 year. Thank you.
Thank you. Dr. Damodar Tiwari.
Hello, namaste to all. I am Dr. Damodar Tiwari from Government Hospital, Bharatpur. I am working there as a consultant pediatrician.
Thank you. Anjana Adhikari.
Namaskar everyone. I am Anjana Adhikari working at BPKMCH Hospital in staff nurse post in pediatric ward. Thank you.
Thank you. Rampukar Sa.
Hello, namaste everyone, and good morning to all. I'm Ram Pukarsa. I'm a clinical psychologist working at Department of Child and Adolescent Psychiatry, Kanti Children's Hospital since last 2 years. And it's a great pleasure to join and get back to you all. Thank you.
Angela Gimire.
Namaste everyone. I'm Angela Gimiri. I currently work in Kanti Children's Hospital in general pediatrics, but I'm interested in pediatric oncology as well as pediatric palliative care. Thank you.
Icha.
Good morning, everyone. I'm Dr. Icha Nagar. I'm pediatric oncologist and currently working in Kanti Children's Hospital. I have recently completed the master's from Dhaka, Bangladesh.
So Dr. Icha is the new member in our pediatric oncology ward at Kanti Children's Hospital. Now, Ranjan.
Dr. Icha, did we meet when I was in Dhaka? I think we did. Many years ago.
Yes, Megan, we met. Hope you remember me.
Yes, I do remember you. Nice to meet again. glad you're back in Nepal and you've completed your training.
Thank you. Okay, we'll talk later.
Yeah.
Also,
Ranjan?
Hello, everyone. It's me, Ranjan Rajgotame from Kanti Children's Hospital. Currently working in oncology department since 1.5 years. Thank you.
Dr. Vishnu Rathgiri.
Hello, good morning. I'm Vishnu Rathgiri, pediatric oncologist working as consultant in Kanti Children's Hospital. Thank you.
Angela Kharel.
Hello and one good morning, everyone. It's me, Angela Karil, working from Kanti Children's Hospital since last 3.5 years. Thank you.
And Muna Adhikari.
Hello, good morning, everyone. I am Muna Adhikari, working in Kanti Children's Hospital since last 1 year. Thank you.
And Saskriti Sapkota. Saskriti, are you with us?
Yes. Hello, everyone. I'm Saskriti Sapkota. I'm public health graduate. Thank you.
And Saskriti is currently working with us on behalf of the NAPCare as program coordinator, especially focusing on the activities for the pediatric palliative care.
Welcome, Sanskriti.
Thank you, sir.
And we have this Galaxy S7 Edge. I don't know who this is. We'll get back to you. Dr.
Rita sister? Maybe. Galaxy, maybe.
Okay, we'll get back to Rita sister. Dr. Bimala?
Namaste, everyone. I'm Bimala Bania, currently working in Kanti Children's Hospital as a pediatrician. Thank you.
Thank you, Dr. Bimala. Dr. Srijana?
Namaste, everyone. I'm Dr. Srijana Gauchan. I'm a general practitioner and I've done fellowship in palliative medicine. So I'm working in palliative medicine as well. Thank you.
I think Dr. Srijana is associated with Parton Academy of Health Sciences.
Yes.
Yeah. And Dr. Hema?
Namaste, I'm Dr. Hema Joshi, currently working as a pediatrician in Kanti Children's Hospital. Thank you.
Dr. Sushma?
Good morning and namaste. I'm Dr. Susma Guru, working as pediatric hematologist and oncologist at Bhaktapur Cancer Hospital, Nepal. Thank you.
And Sarmila Mizar?
Hello, good morning, everyone. I'm Sarmila Mizar from BPKMC Bharatpur Chittaun. Thank you.
Issa Vista?
Good morning, everyone. My name is Isha Vista. I'm working as a clinical psychologist in Kanti Children's Hospital since the past 4 years.
And Dr. Madhusudan?
Namaste, everyone. I'm Dr. Madhusudan Kayasta, currently working as pediatrician in Kanti Children's Hospital.
Thank you, doctor. And Vidya Badal?
Good morning, everyone. I am Vidya Badal, staff nurse at Kanti Hospital. Thank you.
And we have Prakash Paudel.
Namaste, everyone. I'm Dr. Prakash Paudel, pediatrician at BP Koirala Institute of Health Sciences, Tarad. Thank you.
And Pooja Dakal.
Hello, good morning, everyone. It's me, Pooja Dakal. Since working in Kanti Children's Hospital since about 3.5 years. Thank you.
And Rupa Maharjan. Rupa Maharjan.
Sorry. Good morning, everybody. I'm Rupa, Operation Theater and palliative care team. And once day a week, I'm volunteer in Hospice Nepal. Thank you, everyone.
Thank you. So we have this Honor 8S. So Sabita Panthi, sister, are you with us? Can you introduce yourself? I think she has got technical problems. So, any other participants who I have not introduced? Please, you can unmute yourself and introduce yourself. If there are no more introduction left, I would like to welcome Professor Dr. Vishnu for a welcome speech on behalf of NAPCare for the initiation of this program. Over to you, sir.
Thank you, Dr. Sudhir. Once again, warm good morning from NAPCare. I especially want to welcome all the people. I want to thank and welcome the two all people, like international faculties like Dr. Megan, Dr. Natasha, Dr. Peter, even Dr. Stuart is not here. I want to express my special thanks for making this possible. And I want to welcome our Indian and delegates also, Dr. Spandana, Dr. Ishaq, and I want to welcome our Nepalese faculties, NAPCare members, and of course, this training will be worthless if there are no participants. So you participants are heartily welcome. Please actively participate, because the last time, the first part, it was very interesting, very interacting. All participants participated, and our faculties, they taught us a lot. In fact, I also learned a lot in the first eco. So all participants, I heartily welcome. I think with these two words, I want to conclude myself. Thank you.
Thank you, sir. And I don't think we have Stuart with us. And so I would like to ask Dr. Megan, who's actually the core leader who has led to the foundation of the Pediatric Palliative Care ECO Part 1, and she is still with us behind all the activities of this PPC ECO 2. So I'd like to
so much.
Please, everyone, please mute yourself if you are not speaking. And so I'd like to hear some encouraging words from Megan.
Thank you. So on behalf of Two Worlds Cancer Collaboration, who is one of the partners supporting this ECHO project, I'd like to welcome you all. It's nice to see so many familiar faces, and we're so encouraged to see that you're all very keen to learn more about pediatric palliative care and to share together with us. And so I really want to thank all of our volunteer faculty, especially our volunteer faculty from the Hyderabad Center for Palliative Care and from Vancouver, Canada. We have a great number of experts joining to really help strengthen the quality of the curriculum, and especially all of them, many come through Two Worlds and supported by all of the Nepalese colleagues and faculty as well. So I wish you all a very, very good learning program. I'm looking forward to learning with you. And just like Professor Vishnu said, I always learn something when I join with you as well. So last time I learned about how many different languages are spoken in Nepal, which was very interesting. And then I went and read a whole bunch of stuff about the country of Nepal. So I'm very interested to learn more about both Nepal and also how cancer and palliative care is practiced in Nepal.
Thank you, Megan. I don't think you have been to Nepal, so we'll be more than glad to welcome you here once this.
Of course, yes.
Once this corona
this is my virtual travel, right?
Yeah.
Definitely, I will come, inshallah, in future.
Now, I would like, I don't think Dr. Gayatri is with us, so on behalf of the Hyderabad Palliative Care Center, I would like to invite Dr. Spandana to share a few words.
Hi, Sudhir, thank you. Dr. Gayatri is quite busy, so sorry she couldn't join, but she sends her best wishes. And we are very glad to be part of ECHO 2.0 of Nepal. And the first ECHO took me personally by surprise, because we have done previous ECHOs in India, but we have never seen such good participation from participants. Like, they're very active on chat, and the case presentations were very good. So looking forward to Echo 2.0. And the participants, it's usually people who are doing oncology, but I see that there are a lot of general pediatricians and nurses in the crowd. And you people are the ones who can do a lot more palliative care than just specialists. So very glad that you all are taking time to join this Echo 2.0. Thank you.
Thank you, Dr. Spandana. Now, I'd like to take attention from all the participants and regarding few norms for this training session. This, as we all know, this session will have 1 hour session every Thursday from 7 a.m. to 8 a.m. And in this session, we will be taking attendance, and the attendance will be taken 15 minutes after the session starts. So everyone who misses the attendance will have to go through the visual with the recordings of the session. And at the end of the overall training program, 80% attendance is mandatory for the certification. So please kindly check your attendance and be prompt and punctual. And the other thing is, for the purpose of attendance also, we need your name in the Zoom ID. So today also I've seen few names of the brand names of the mobiles or the laptops. So please, let's not repeat it from the next session. You please confirm that your name is there in the Zoom ID, so that we can verify your attendance. Otherwise, your attendance can be missed. And also, when you are not speaking, please mute yourself. And I repeat, please mute yourself when you are not speaking, so that it won't disturb others. And to go with our schedule, I'll just like to show you a screen. Hope everyone can see this screen. So this will be the format of our class. We'll begin at the 7 a.m. sharp. So for 5 minutes, we'll start with the welcome and introduction. It will be done by the facilitator. And from 7:05 to 7:30, for 25 minutes, there will be a didactic presentation. This is just an example of topic. So after this 25 minutes, in the meantime, in the 25 minutes, if we have any query or questions, we can write it down in the chat section. We have our facilitators, our faculties who are dedicated to respond to the chat also. So if there is any doubt, we can always put our questions, our queries in the chat, and that will be answered. And some questions that really needs further discussions will be discussed at the end of the session. So further discussions, as I mentioned, will be done for 5 to 10 minutes, and then there will be a case presentation. So for this case presentation, we have allotted few participants who will be writing the case presentation that would be somewhat relevant to the topic of presentation, and they will present the case 3 or 4 days in advance, so that we can recorrect the case and we'll get back to the participant. Most of the participants who have taken our pediatric palliative care part 1 already know about this. And after that, we'll have discussion about the case, and there will be active discussion, active participation from both the faculties and the participants. And finally, we'll have the summary of the case and we'll announcement for the next upcoming case. So, and this will be the rough overview of the topics that we are going to cover. So the next will be communication and breaking bad news, and the other will be anxiety and grief issues. So with that, we'll add the name of the didactic speaker and case presenter also. For that, if your name is there in that, we are sorry that we couldn't involve all the participants. So we'll try to involve participants from every hospital, every field possible. Anjana Adhikari, I think you're you have to mute yourself. And the detail of these topics will be sending you today. Along with that, if still there is some query, you can put the query in the chat. For the today's program, this will be the end of the formal opening program, and we'll go with the introduction to the pediatric palliative care, and Dr. Krishna Sagar will be presenting on the pediatric palliative care. Dr. Krishna Sagar?
Yes.
You can share your screen.
Is okay? Sudhir?
Yes, you can enlarge it. You make it full screen. Yes, good.
Good morning to all. Especially thanks to Tools Cancer Collaboration, Center for Palliative Care, Hyderabad, and all the supporting hands to make this eco session part 1 successfully, and we are going to conduct part 2 sessions. I'd like to welcome to all the participants. Institute of Health Science, Dharan also joining in this session. So I will welcome to all, and I will going to present about the introduction to pediatric palliative care. I thank Dr. Peter for I am taking the slides from the some of the slides from part 1. So I especially thanks to him. Sudhir, I am audible. Hello.
Yes, sir, you are fine to go.
Okay.
Please go ahead.
Thank you. Just learning objective of this palliative care. Some problem in the screen. Okay. Define pediatric palliative care and the palliative care approach, and, including model how and when we can give the palliative care. Identify children who could benefit from a palliative care approach and the opportunity for palliative care interventions as different stages of disease. Define and describe the role of primary care clinicians, palliative care teams, hospice, community-based service is provided palliative care throughout the trajectory of the child illness. Describe practice which facility integrate of a palliative care approach into your own practice. Let's say, what is the pediatric palliative care? All of us know it is an interdisciplinary collaboration that seeks to improve the quality of life of all children with life-threatening condition as well as their families. It mainly focuses on prevention and relief of suffering, regardless of the stage of the disease, and comprehensive address the physical, psychosocial, and or special need of the child and family. So, key features of pediatric palliative care. We already knew from the last sessions, not limited to the last few days or weeks of the life, just like end of life care, just like, but it can be provided along with the treatment to control the disease, to control the suffering, to control the symptoms. Sometimes we can start before the diagnosis. Maybe in some of the countries like ours, where the patient, they have lots of suffering, still the diagnosis is not confirmed. So even at that time, you can give lots of palliation, lots of supportive care to the child to make them happy and better feeling. Aim to improve the maintenance of quality of life, and it is a holistic care, physical, psychological, spiritual, and social. And it for not only cancer patients, but we can deliver to the non-cancer and even the genetic disease, congenital disease, and lots of the other abnormalities you can reach for cancer. And it requires the care that is best provided by interprofessional teams, not only one person, just like pediatrician, palliative care physician, lots of interdisciplinary team is involved, as we know. And this is the disease of the palliative care history. So lots of 1950 and 2000, lots of development in the pediatric palliative care. When is it appropriate to start pediatric palliative care? Should we offer a diagnosis and continue throughout the course of illness, whether the outcome is cure or not, whether the child is going to cure or child going not going to survive, but we have to give the best possible supportive care to the pediatric and adolescents who are on their suffering. This is the model for the pediatric palliative care. So if pediatric care starts around the diagnosis, and initially we have to continue the cure or control type of disease modifying treatment. So even though we can give the some supportive care, but if the disease not is going to cure and disease progress, and the supportive and palliative care component is still increasing, and even the terminal stage in the life care, the still palliative care is increasing need toward the end of life. And beyond that, even bereavement is there to the rest of the family and other things to be continue as a part of palliative care. So from the diagnosis till death, even beyond the death, throughout the illness trajectory, the palliative care is needed. Which child needs the palliative care? All of child, almost all child who have the disease may require the palliative care in some part of time. So these are the just like a life-limiting condition for which there is the likelihood of the death before the adulthood. Life-limiting conditions just like congenital disease or maybe metabolic disease and other congenital disease, and life-threatening condition which is curative treatment may be feasible but fail to meal, just like the cancers and other progressive disease. And some of the progression, ongoing deterioration of health, other functional status just like CNS disease and brain CNS disorders, congenital disorders, where the child is not going to survive till the expected in a certain pediatric expansion of life. 55 per thousand children in the South Asia need palliative care. So there is lots of need of the palliative care. And there are the four type of categories of patients who can this a life-threatening condition, curative treatment available but may fail at that time, long period of treatment which aim to prolong life but premature this anticipate this condition, and a progressive condition where treatment is palliative from the diagnosis, severely disabled that lead to extreme vulnerability to complication and premature death is expected. This is the type category 1 where the life-threatening curative treatments available but may fail, just like cancer, congenital or acquired heart disease, infections like meningitis, encephalitis, even malaria, MDR, TB, and other conditions, organ failure like liver failure, kidney failure, maybe heart failures, organ failures, blood disease, the thalassemia, sickle cell, lots of other hemolytic disease, even and hemolytic disorder and other myelodysplastic syndrome and other blood disease there, and neonatal prematurity and its sequelae. So in this case, the disease trajectory from the diagnosis and then remission treatment and again remission and treatment and death. So the childhood condition is going to deteriorate slowly over a months to years. So at that time, we in the most of the time, maybe along with the treatment, maybe we have to combine the this pediatric support for palliative care. These are the category 2 disease in pediatric where the long period of treatment which aim to prolong life but premature death is just like HIV and AIDS, cystic fibrosis, muscular dystrophies, spinal muscular atrophy type 1, chronic or severe respiratory failure, and severe immune deficiencies and others conditions. And again, in this case, the diagnosis initially few years, the condition may be stable, and over a period of years, the condition is going to deteriorate, and there is lots of ups and downs, and ultimately, child going to die before the expected life of expectancy. So, in this case, we have to have palliative care. This is the category 3, where the progressive condition without curative treatment option, just like chromosomal disorders, metabolic disorders, neurodegenerative disorders. These are the conditions where there is no curative treatment, but they are progressively they live for the longer times throughout with the illness. So diagnosis and initial phase sometimes they are much stable and then slowly deteriorate over smoothly, a progressively disease till death over the many months to years. These are the category 4 where severe cerebral palsy, just like severe disability that lead to vulnerability to complications which lead to premature death, just like severe cerebral palsy, severe brain injury, trauma, hypoxic brain injury, severe infection, meningitis, and other CNS infections, just like encephalitis and severe brain malformations, holoprosencephaly, lesioncephaly, schizencephaly, and lots of brain abnormalities. And in this case, the disease child condition initially looks like stable once the diagnosis is slightly deteriorated and the prolonged over years. These are the distribution of children in need of palliative care at the end of life of the disease groups. Wise commonest may be congenital anomalies, and, and there is lots of endocrine, blood, and immune disorders. Protein in developing countries, the protein malnutrition is one of the causes, like neonatal conditions, meningitis, encephalitis, and sequelae, and HIV/AIDS, even cardiovascular disease, and even cancer, some neurological conditions, and kidney disease. These are some of the commonest conditions where pediatric palliative care is needed. How and where the palliative care provided for the children? Yeah, palliative care where responsibility is the all share responsibility of all the professions, just like specialist palliative care approach, maybe from where anywhere specialist level, pediatric palliative care team comprises the different possible specialty and multidisciplinary team. Maybe it can be even primary care patients, maybe family patient, pediatrician, even adult palliative care, and disease can be started from the disease diagnosis to the death throughout the illness trajectory, so is required. And where we can give pediatric palliative care to the children anywhere where they are. Maybe they are at home, community home care, community based palliative care service is increasing over the period of time worldwide. In hospitals, community hospitals, adult focused palliative care center, maybe tertiary hospital, specialist pediatric palliative care team, and others. And even when there is a special pediatric hospice and palliative care and the hospice center, and other area, even in the acute care setting, or maybe a hospice area, or maybe in the community, everywhere where there is a child, we can give the palliative support, maybe in most of the areas. Pediatric palliative care is the best provided by the multidisciplinary team, know, because even in our groups, there are lots of physicians, nurses, even the psychosocial counselors, social workers, psychologists, play therapists, and maybe with the other, we can invite the other disciplines just like pharmacists, occupational and physiotherapists, arts, music, and recreation therapists, special care and volunteers, and other supporting hands carers. Even we can invite in the team to combine our effort to make the child easy during this illness and then end of life. Area of care for pediatric palliative care, maybe respite care, maybe pain and symptom. These are the area where the medical respite care is required. Pain and symptom management, end of life care. It may be the community-based care, maybe perinatal palliative care, grief and loss counseling. So these are the area where we can focus for the pediatrics. How to integrate palliative care principle into your practice, and how. So we have to integrate the palliative care not only purely palliative care setting, during our acute care setting, maybe in chronic disease, anywhere we have to integrate the palliative care. So the palliative care approach, generalized level palliative care, we have to identify the palliative care, we have to assess, make the plan, and then manage the team in anywhere and any setting and during at any time. We have to identify the patient early who may benefit from the palliative care in any settings. We have to assess their understanding of the illness and information need. What are the symptoms they have? What are the psychological special need? What is the quality of life? Then value wishes and preference of this child and their families, and plan advanced care planning, maybe goal for care and care plan, treatment plan, link to resource and other care plan, prepare for emergency condition which may arise and manage all the symptoms, psychosocial, and even when the essential discussions and when we have to refer when needed. The three key practice of the palliative care approach for children and family, understanding the illness from the child and family person. So we always think the child understanding how the child is and the family's values and family perspective. So carer and child both we have to address as a whole. Need of the parent of needs of parents of seriously ill child. Maybe parent they have lots of things, recognition from the clinician that their child is the best, feeling that they are a good parent, clear and honest information we have to give, informative, communicated, caring and sensitive way, trusting relationship with the clinicians, with the whole family, maybe children or the other team, and even when they require, maybe we have to prepare for the death, maybe for the good death, and maybe we can say the quality of care to the end of life. Needs of seriously ill child, reassurance, maybe nutrition, and in age, maybe simple and maybe age appropriate information. Even when they can play, we have to make them to play and make them happy. Play is a safe outlet of a child, express emotion, stressful situation, maybe choice and succeed to help them understanding their life experience, being in the hospital, having cancers, and give the child and family information where they need. Uh, Initiating family wants clear and honest informations, including prognosis information expressed in the if percentage available. In communication, honest information about prognosis does not take away home. Hope is supported by the trusting relation between the clinician and their patients or families. We have to provide the good direct goal directed care. What is our the we have to find out and we have to sketch out what is our goal for the specific disease directed care. Maybe approach, maybe primary goal of healthcare, maybe sustain life, or maybe integrate comfort and curative lifestyle therapy, maximize symptom relief or quality of life. Maybe it may be intensive, maybe intensive targeted, maybe limited targeted, and maybe team, maybe consultative, maybe collaborative or primary goal. So pediatric palliative team role maybe anywhere consultation. Sometime only we can do the some type of consultation. Some we have to do the collaboration, and sometimes we have to give our as a primary lead in the collaborative team the more model of the care. Uh, on the summary, a pediatric palliative care is an approach which focuses on improving quality of life, maintaining dignity and of the sufferings from both the child and their family, and we have to reduce suffering for both the family as a whole. Palliative care is needed for children with a variety of life-threatening or life-limiting conditions, not just cancer. Palliative care should be initiated early in the illness trajectory, not only at the end of life, so throughout the courses. Palliative care can be done alongside treatment to control the disease. Identifying patients who could benefit from this approach earlier, each one of us can make a difference and provide palliative care. Maybe it's always not need the palliative care to provide the doctors and nurse, maybe, but anybody who can have this knowledge to make the palliations of the symptoms child, we can deliver maybe alone or jointly. Children and family need clear information to have appropriate hopes and make the information informed decisions. So this is the summary of the course. Thank you very much for the listening, and maybe we can discuss it something sometime is there. Thank you very much.
Thank you, Dr. Krishna Sagar. Can you unshare your screen? Stop sharing your screen. Yeah. Can you stop the screen sharing?
Yes. Okay, it's okay.
I think I'm done. Thank you, Dr. Krishna Sagar. He has given the theme of the pediatric palliative care, and he has highlighted that it involves not only the children with cancer but with other chronic diseases also, and it doesn't involve the children only, it involves the whole the family, and it's beyond the disease also, and it involves the spiritual aspect also. Thank you, Dr. Sagar, for your fine presentation. So this will bring us to the end of our today's session. If there are any queries for the participants, uh, the floor is open for discussion. Please unmute yourself and you can have discussion with the panelists and other participants if you have any questions. Any questions from any participants? Yeah, so there was one question in the chat. So the question was by Dr. Megan and say, what team members have you seen giving palliative care? So in this, someone from Bhaktapur from BP Koirala Cancer Hospital, Bharatpur, Himal sister, are you with us?
Sharmila sister.
Can someone from Bharatpur explain how the team works at your setting?
Anjana. They are quite muted. Yeah, in Bharatpur, we have palliative care clinics every day. So we have to have, we used to have the multi-team, just like doctors, nurses, dietitian, physiotherapy, and we can invite the other disciplinary, even as volunteers, social worker and volunteers, and other disciplinary where the child is child or any other persons who have the need the palliative care from the acute care team. And sometimes we can invite the play therapy, sometimes we can invite the religious peoples according to the this patient's need. So this is not the good, not a big team just like in westerns, but we have the some possible team in our setting where we can give the daily outpatient clinics in person. In once a week, we have to give. We had to go to the community for the community visit for home care. Thank you.
So talking about Kanti Children's Hospital, we have 4-bedded pediatric palliative care, which is inside the oncology unit, and it is basically looked after by the physicians and nurses from the working in the oncology ward only. But we also have one social volunteer, one nutritionist, and we are, every alternate day we get rounds from our psychology team also, and they also visit us when needed. Apart from that, we are planning to extend our palliative care unit and trying to.
Good morning.
Vandana sister, you need to mute yourself. Yeah. So apart from that, we are planning to include other pediatricians and other staffs from other non-oncology wards also to support the palliative care in Kanti Children's Hospital. We have Dr. Srijana. Can you share some experience from Patan Hospital?
Actually, at Patan Hospital, we do not have a or a ward. We just look after the people or the patient who needs care at the respective site. Like we do adult palliative medicine. So in that case, like if someone needs service at surgery ward, we go to the ward and give the service. If someone needs it at medicine ward, then we go to the respective wards and give the service there. So we do have the onco ward. If the patient needs only palliative care, so we shift the patient to the onco ward and start the treatment, like take care of them over there. And recently, after the last PPC echo, we've started the children palliative also. We do not have a lot of children needing palliative care. There were few who needed palliative care, so we do go to the children ward and provide the service as and when needed. Thank you.
Thank you, Dr. Srijana. Do we have Ruth Powie? I don't think I've seen her. Dr. Ruth, are you with us? I don't think she is with us. So, Dr. Professor Vishnu, are you with us? Professor
Yes,
Vishnu?
yes.
Yeah. So you have new setup of palliative care at Bhaktapur Cancer Hospital. Maybe you can shed some light on that.
Yeah, in Bhaktapur Cancer Hospital, there is separate palliative care department also, so which look after all adults and the pediatric patients with the cancer for the and the palliative care. And then we have a pediatric oncology, and in fact, our pediatric oncologist has joined the program. And pediatric oncologists in Bhaktapur Cancer Hospital provide oncological care, and when needed, the palliative care also to the children. So we, from 2 points, we provide it. Maybe in the future, we'll like to improvise some delivery system also.
Thank you, sir. Dr. Spandan,
Any thoughts from the Dharan, Professor Prakash Paudel? Are you here and can share some idea? Professor Prakash Paudel? Dharan, maybe he's not
Yes,
here.
yes, I am here.
Yeah.
So,
Can you share some few words, your experience and the planning?
So actually in Dharan, we do not have separate pediatric oncology subspecialty, but there are lots of children who need palliative care, like children suffering from disabling neurological conditions. As Dr. Krishna Sagar said, we have lots of children with muscular dystrophy, spinal muscular atrophy, and lots of other. And since BPKHS covers large area of Nepal, eastern part of Nepal, and most of the children from eastern part of Nepal come here, even for the end of life care. So it is a much needed field. So we feel the need of palliative care here, but because of shortage of basic infrastructures and trained human resource in the field of pediatric palliative care, it's still in preliminary phase. Thank you.
Thank you, Dr. Prakash. And so we'll have, we're running short of time, so we'll have just few words how the palliative care services are working abroad. Kamara, would you like to?
Thank you. I'm just so curious to learn more about the services there, and I'm putting a few questions in the chat. You know, I think for us in Canada here, particularly, you know, we have a huge amount of land with not very many people in it, and so our palliative care is concentrated in our bigger cities. And one of our challenges is how to give virtual care across our large province to help families even when we're far away from them. And so one of the things we're working really hard at is trying to have availability to families 24 hours a day, and to other physicians and nurses and team members that don't have expertise in pediatric palliative care, they can consult with us. So I guess to say that depending on where you are in the world and who your professionals are that are working, constructing a program that works for you and for the families and the children is very individual. And I really look forward to hearing more about of how you're doing that and how this can grow.
Thank you, Kamra. Any views from Dr. Megan, Dr. Natasha, or Peter? Would you like to share how it's working abroad in the place you are working?
I just wanted to add a few more points from what Tamara said. Even though we have a hospice with several beds, the majority of the care that we provide families is to the location that they're at. And so quite a lot of our work is done at the hospital, which is separate from our hospice. So on the neurology ward, on the general pediatric ward, in the NICU, neonatal intensive care unit, and on the oncology ward. And as Kamara has alluded to, most families, they want to be in their local community, whether in the local hospital or in their home, so that we figure out a way of how we can bring our team to them, providing advice to the families at home or to the specialists that look after them closer in their communities.
Thank you. Thank you, Peter. A quick few words from Dr. Spandana.
Yeah, I was just thinking the structure of the team that we have here is we have a doctor, a nurse, and a social worker. We are very privileged. That is not the case with many of the programs, but we consider those to be the basic to divide the work. And also, I think there is a lot of collaboration with oncologists and pediatricians also, because we work at a tertiary pediatric hospital. So they are the people who have to identify the palliative care needs of children and involve the palliative care team. And beyond that, we have OPD services, outpatient, inpatient, and we do home care services. And we have a hospice. And the most challenging thing of all this is promising phone call follow-ups 24/7. And we try to be available. So I think these are the services we do here at Hyderabad.
Thank you, Dr. Spandana. So with this, I think we will round up today's program. Before ending up the program, I'd like to take attention from the participants and say that please kindly change your name or the Zoom ID for those participants who still have, I can see Galaxy S7A's. So that is must for attendance, and that is Honor ATS. This is must for attendance, so please kindly change your name and be active in the group also, in the WhatsApp group also. We can put forward the questions offline in the group also. In the group, we'll be sending you a survey. Please kindly fill up the survey. That will be crucial for us to gain the information about planning other activities and further activities for the pediatric palliative care. We'll be sharing the link on the WhatsApp group. Please kindly fill up the survey as early as possible. So with this, I'd like to conclude today's session so that we'll meet again on the Thursday at 7 a.m. And for the faculties, we'll have a debriefing session. We'll reconnect again. Thank you, everyone. Bye-bye.
Thank you.
Thank you. Bye. Excellent conducting the session, Dr. Sudhir. Congratulations to you. You did excellent job. Thank you.
Thank you, sir.
Thank you.
Have a good day.